Hi, great, thank you. So thank you so much for joining us this morning. We are so pleased that you were able to make time to meet with us this morning and meet with your colleagues. We hope you have an opportunity to interact with the panelists this morning, as well as with each other, network, and we will be around after the formal presentations in the program to speak with anyone who would like to discuss any of the programs that we mentioned this morning. I am Ann Dijak. I'm with PCDC. I lead our capital investments program. We are a CDFI, and I'll explain a little bit about who we are in case you're not familiar with us. We are what is referred to as a CDFI. We're a community development financial institution, which is basically a mission-based lender. We operate under the CDFI fund under the U.S. Treasury, but we are basically providers of capital, strategic investments, capacity building, technical assistance, and we also provide advocacy and public policy work on behalf of this sector. Unlike many CDFIs who are focused and committed to serving a number of different industries, everything from charter schools, social service, arts organizations, we are focused solely on primary care, and we have been doing that for over 25 years. Well, I'm lying, actually, almost 25 years. Next year is our 25th anniversary. And we have provided investments that have made possible over $850 million worth of projects for community health centers in low-income communities, underserved areas. And most of that has been in New York. Our roots have been in New York. We work nationally now, but we do a great deal of work still in New York, and our heart and soul is in New York. So we're delighted that you were able to join us today to hear about our programs in New York, as well as the programs that are provided through our colleagues at OMH and OASIS. We're delighted that our colleagues from OASIS, OMH are here with us. Dr. Ruggie is here from Hudson Headwaters, and will be providing some introductory remarks to kick off this morning's breakfast. Also delighted that our colleagues at DASNY are here, who have been incredible partners with us through the creation of the New York State Community Health Care Fund. So thank you also for joining us. I have the pleasure of starting the breakfast and introducing Dr. Ruggie, who I think many of you know quite well. Let me just pull up, because I don't want to miss, he's got incredible credentials, and I don't want to miss any of it. I know you're going to be embarrassed by all this. Yes, very, very modest, but many of you know Dr. Ruggie is a family practitioner. He's the founder and executive chairman of Hudson Headwaters Network, which operates 17 community health centers throughout the Adirondack, North Country, and Glen Falls region. Over 5,000 square miles is covered by the network. It consists of Warren County, parts of Clinton, Essex, Hamilton, Saratoga, and Washington counties, so quite a large expanse of communities that they're serving. They provide over 400,000 patient visits annually and serve more than 1,000 people a day. Very impressive. Dr. Ruggie serves as a senior policy advisor on a number of prominent committees and councils, including the Primary Care Behavioral Health Integration Work Group for RMI, where he serves as co-chair, and the New York State Public Health and Health Planning Council, where he chairs the Committee on Health Planning. He has previously served on the Medical Review Board for the New York State Commission of Corrections and the New York State Rural Health Council. Additionally, he chaired Governor Mario Cuomo's Healthcare Advisory Board and served such committees as the New York State Commission on Graduate Medical Education and the Robert Wood Johnson Foundation Rural Health National Advisory Committee. Dr. Ruggie received his BA from Williams College, his MTS from Harvard University Divinity School, and his MD from Yale University Medical School. And we are delighted that he serves on the PCDC board and recently has joined us on the loan committee as well, and we hope he stays. And he also serves on the board of Chicanes, which is the Community Health Center Association of New York State. So without further ado, Dr. Ruggie.
Well, Ann's now given my entire talk. I am vocally challenged, so if you can't hear me, just raise your hand and I'll try to shout louder. But I would just observe, I think we're all here today because the worlds of 28, 31, and 32 are colliding and coming together. What we see at Hudson Headwaters and our health centers is integration in a whole new way. We have a staff of psychiatric nurse practitioners and counselors. We have an MAT, medication assistance treatment program, that is really indispensable to our patients and represents a key part of primary care as far as we're concerned. Interestingly, instead of this leading to any sense of competition with the agencies and the organizations that are directly providing those services full scope, it's led to new forms of collaboration and interdependence and referrals back and forth and helping one another that is at the community level really indispensable to our future. And now we're hiking it up to a new level. I think there is broad recognition that primary care needs a broad definition and includes all the body parts and all the body habits. And only by having that kind of approach and making primary care truly robust do we have any chance of achieving the triple aim of really improving care, really improving the health of our communities. And by the way, saving money along the way. It's the key to our future for all of us. And this is being recognized, as Ann mentioned, with the RMI, the Regulatory Modernization Initiative. I have been the co-chair of the BHS Primary Care SUD integration effort. And what that has led to is a commitment on the part of the state agencies in developing something new, a new acronym, LILs, Limited Integrated License. So that instead of facing the regulatory burdens or the limitations on care, that we can bring one service or another or all three together in an expedited fashion involving only one department and not all the regulatory tape that we have been accustomed to so far. So there's real movement at the state level. And so with that, PCDC, not in catch-up mode, but really leading the way, has been just indispensable, I think, in terms of us as Article 28 primary caregivers. I am a beneficiary, or Hudson Hill Waters is. Some years ago, we had 2 projects going on simultaneously. Then it was a lot for us. We had a new health center going up with conventional financing, that is community fundraising and grants. At the same time, we're gutting a department store, actually, in Warrensburg, to become a dental center. At that point, the only building in town with an elevator. Very big deal in a rural area. And it was PCDC financing that made that possible, and really on a preferred basis that would not be obtainable through any kind of conventional financing mechanisms. The history of PCDC begins with Mayor Dinkins. I think it was Mayor Dinkins. Really to be a New York City project, to go to the most difficult to serve neighborhoods, the most poverty-stricken neighborhoods, and having achieved success in the city, decided to expand statewide, which led to my being invited to become a board member, which has been an insight. In the same way, in the primary care field, we have all these acronyms. You know, we're pursuing FQHC, we pursue PSMH, as you've already heard. PCD is out there on the financial side pursuing CDFI, NMTC, all these things that I've never heard of, but actually make financing possible. And it's possible in the PCDC world because, and I see this firsthand, this is the strangest of beasts. It's a financing agency with a heart, and one with a sense of mission and commitment. I was asked to be on the loan committee, as you just heard, because the concern is the financiers need to know a key criterion for loans is how big the need is, not how big the balance sheet is. And the reminder at every step of the way of what we're really there for together to provide, and that is care to the most difficult to serve patients and find ways to make it work. And by doing that, reform the health system from the inside out. Big challenge. This is part of that process, and it's really fine to see so many people here from all the various disciplines. So with that, we'll go on to substance. Thank you.
Thank you, Dr. Raggi. We'll now start the panel discussion, kick that off, and we're delighted, as I said, that we have leaders from Office of Mental Health and Office of Alcohol and Substance Abuse Services. My colleague Bill O'Brien, who is sitting to my right, will be the moderator this morning. And I wanted to provide a little bit of background on Bill. I have the pleasure of working with him every day, and I know many of you know Bill and have worked with him as well. He is responsible for leading our capital investment team's efforts in ensuring that we are meeting the needs of you, the direct service providers in the communities in needs. He works very closely with leaders of many community-based providers to understand what your needs are and develop and structure traditional financing, structured financing that meets those needs, and he leads a team of our lenders in doing that. Bill comes to PCDC after a 25-year career in more traditional lending. He's been a vice president and senior vice president at a number of different banking institutions, and has managed nearly $2 billion of loans, including $200 million of healthcare investments. Everything from hospital financing, physician-owned practices, long-term care facilities, and actually helped launch a securitization program in the Netherlands for healthcare financing. He received his BA in philosophy from Cathedral College of the Immaculate Conception, master's in philosophy from New York University, and an MBA in finance from Manhattan College. So I'm delighted to introduce you to my colleague Bill, and I hope you have an opportunity to talk to him at some point, either this afternoon after we break or down the road.
Thanks, Ann. Thanks, Ann. So what we're going to be doing now is hearing from our panelists, different folks on the various topics of needs for capital expansion and various programs that may be afforded to the agency members. So without further ado, I'll do some of the introductions. Most of you, I think, know everyone here, at least individually. We'll start with Tim Donovan. Tim serves as the Upstate District Director of the New York State Office of Alcoholism and Substance Abuse Services. In that role, he oversees the 5 regional offices operating in the areas of the state that are north of New York City. The regional offices are involved in nearly every facet of activity, both funded and non-funded provider operations. Mr. Donovan has worked in the regional offices since joining OASAS in 2001. Prior to that, Mr. Donovan served as an addictions counselor and managed outpatient and residential programs of not-for-profit agencies in Albany's South End. Tim is a Marine Corps Vietnam veteran. He's received his bachelor's in social and rehabilitation services from Assumption College in Worcester, Massachusetts. He studied theology at the Pontifical University of St. Thomas Aquinas in Rome and obtained his MA from SUNY Plattsburgh. He lives in Queensbury with his wife Diane and children Dan and Quashon. Moira Tashian is the Associate Commissioner of Adult Services with the Office of Mental Health. Moira has over 30 years' experience working within New York State's mental health system of care, including as a community provider and then within the state. Prior to becoming the Associate Commissioner, Moira was the Director of Housing Development and Support within the New York State Office of Mental Health. Moira has a bachelor's in social work from Siena College and an MPA from Marist College. And then finally, Lori, really immediately to my right, Lori Glass is PCDC's Director for New York State. Her activities are focused on leading the effort to expand and sustain community-based health services throughout the state of New York. Lori brings extensive lending and community development experience, having most recently created and launched a CDFI in Virginia, Appalachian Community Capital, where she served as president and CEO. She was a director at the Reinvestment Fund, a well-regarded CDFI partner of PCDC's, and led early-stage development of the Pennsylvania Fresh Food Financing Initiative, which was a public-private partnership. She also opened the Reinvestment Fund's Washington, D.C. office and led business development activities there for 3 years. Prior to that, Lori has held positions with the CDFI Fund, which is a division of the U.S. Treasury, and at J.P. Morgan Chase, and has sat on boards of the New Markets Tax Credit Coalition, Opportunity Finance Network, that's the trade association for CDFIs, and the National Housing Trust Community Development Fund. So 3 individuals with a lot of varied but very deep experience in financing and expansion of health facilities. So we'll begin the question and answer period with a couple of questions to the panelists that have been prepared. First and foremost, Tim, we'll start with you, if you don't mind.
Sure.
How do you see expansion and transformation activities in your market? And can you share some information about solutions and programs from your agency to help support these activities?
Of course. First, I'd like to say that any of you who came expecting to see and hear from Rob can get a refund at the door. I think there's a slide that shows a map of the state. OASIS has been in an expansion mode in response to the heroin and opiate epidemic over the last couple of years, and this shows some of the things that we have been doing and are doing in response to that. A couple of years ago, we issued an RF. I'm not sure it was an RFA, RFP for rapid capital expansion, and under that, there were awards for 20 beds to Women's Christian Association Hospital, 25 beds to in Livingston County, 20 beds in Cattaraugus County, and 15 beds in Erie County. And on the 822 side for OTP slots, there were 100 slots in Schenectady County added, 250 slots in Onondaga County, 100 OTP slots in Erie County, and 150 slots in Genesee County. Very recently, we issued an RFA for 75 beds of medically supervised withdrawal services. That was put on the OASIS website about 2 weeks ago, I think. Anybody's interested in applying for that should look into that. In addition, we have opened and are operating recovery centers, youth clubhouses, open access centers. One was just opened the other day in Rochester. And there's been additional OTPs or opioid treatment centers opened. There were 11 new programs opened for an additional 2,500 slots within the last year or so. And we've lifted capacity in 25 programs around the state for an additional about 1,500 slots in the last year. And then the opioid STR grant has begun operation in 16 high-need counties around the state. Many of those in the immediate Albany Capital District area. I see Saratoga counties here, in Montgomery County among those, Greene County. Some of those come to mind right off the bat. Also Sullivan, Ulster, the ones that are starred are the STR grant counties on the map there. This sheet that's passed around shows the location of some of those programs, shows the name of the provider, the phone number, and the county that they're located in. So that if you're from those counties, if you have a need for that service, if you have a family member that's seeking services, you can you can call the Family Navigator, for example, and help the family member get assistance with getting into treatment if they're having trouble navigating our system. Sometimes it can be a little bit confusing for family members if they have never gotten into treatment before or tried to get into treatment before. We're also doing integrated care, integrated licensure with mental health and our DOH license programs as a way to expand service capabilities around the state. So there are a number of new ways that we're trying to expand services and make more service availability around the state.
Great, thank you, Tim. Moira, would you like to?
Sure, and thank you very much for having us here today. It's exciting to see new faces and old faces in the room. As far as systems transformation, the Office of Mental Health has been working very closely with OASIS and DOH to take a look at, where do we need to move, what do we need to move, and how do we do it. So we're all working steadily in that process. One of the barriers in housing, you brought up housing, Tim, is that it takes a lot of money, it takes a lot of different funding sources to pull together to develop some of the programs both for low income and special needs individuals throughout the state, whether that be in Schenectady, Albany, Manhattan, or Yates County. It's still a significant amount of funding streams coming together, which also has to, we have to be able to convince the funders that they can trust us, that this project will be sustainable and will be good for the community. So it's exciting to see your organization becoming one of our partners in doing that. In some cases, we've had 11 different funding streams in one of our projects in New York City. So think of the complication for that provider as well. So as I said, it's exciting to be here and begin partnering with you. One of the expansions that we're also looking at is crisis. We have to work together as a system to identify the crisis needs throughout the state. We also know that every county has a different character, has a different need, and a different composition. So we're working to develop really 3 sectors, one being the mobile capacity, the second being the respite, a residential component of that, and the third being the component of crisis stabilization, which will be more like a clinic-based, although it won't be a clinic per se, it'll be a series of integrated systems. And I know OASIS, you already have one open in Dutchess County that's quite successful, which is great. And if you want to flip my side around. We've also had to take a look from a clinic perspective, what's going on in the market. So when we have to really look at the transformation activity, we look at 2 things. One is the consolidations and the other integrated care. Why would people consolidate? Fiscal pressures. They're very apparent in the system. 20% turnover in our clinic providers in the last 3 years, and 28% are considered to be at financial risk over the most recent system-wide fiscal review. So that has resulted in new clinics opening and consolidation and expansions in other areas. So really that coming together. But also that ties next into integrated care. As I said, OMH, OASIS, and DOH have been exploring, are working together, but also in part of that integrated care process, exploring the single license option. And there are some challenges with that, as we all know. But it would allow the holder of one license to provide all three services. And one of the questions I know people have struggled with is, well, couldn't it be just all collated? There are some federal challenges with that right now. That's why that hasn't been able to happen. And of course, we're part of a demonstration project in 13 sites for CCBHC. So that's a certified community behavioral health care clinics. And again, that is not singly OMH. That is OMH, OASIS, and also DOH. We also, we know we have issues and challenges, but we also have some solutions that we're working on. In the fiscal area, we've been providing technical assistance for billing efficiencies. We find that, especially in the bigger hospitals, people aren't billing, or they're not billing accurately. And so, in essence, they come back and say, we can't run our program, and we look at where you haven't billed, okay? If you have bill, you might get some money. So we've been working pretty closely with that. And, fiscal auditing and our VAP funding, which is really funding for agencies or clinics that are in fiscal challenges. And again, I mentioned this already, but for our integrated care, the CCBHC, the DSHRIP consultations, and of course, developing the integrated outpatient services, which will be utilized by Article 31 and 32 clinic providers. So that's kind of where we're at with the Office of Mental Health. It's everything's a rapidly moving target, and sometimes it slows really down, and then it's really fast again. And so again, I appreciate your partnership and all of ours here in the room.
Great. Thank you, Moira. Before we go on, I just want to, just a housekeeping, there are a few empty chairs up here if anybody is without seating in the back, including our lounge area on the left over here, which is kind of interesting.
It looks very
But
comfortable.
it is.
I don't know if you've seen it. It's very comfortable.
It is very interesting. It is very interesting. Lori, in terms of, do you want to discuss PCDC? So we've heard about integration and expansion, so some of our programs and solutions.
Right. Thank you. First off, I want to say thank you all for coming out and showing up. I spent the past few months traveling from Plattsburgh to Albany and from Buffalo to Albany and Syracuse and Rochester, through the mountains, and really getting to know providers, Article 28, 31, and 32 providers, and getting to know the communities that you serve in a very, one-on-one way. And it's really informed the work that we do here at PCDC. And my goal is, for those that I haven't been able to sit down one-on-one and meet with, is to continue to do that and to really, deliver to you a lending program that's responsive to the needs in your community. So I'd like to start out with this slide that really talks a little bit about the data and the metrics behind PCDC. The first number I'd like to talk about is $850 million of facility financing. That's a very big number, and what it reflects is the total project costs of facilities that PCDC has been a part of. And when Mara mentioned, one project with 11 funding streams, many of the projects that we finance, we also see multiple funding sources that are required to get a project up and running. So we've participated in the next number, 130 health centers. We've financed in part or in total 130 health centers, not only in New York State but also across the country. The value of that is that our lending team, we consider ourselves experts in financing this space. There are other groups that may finance housing and community facilities. They may finance schools and a broad band of nonprofit facilities. But our space is dedicated to Article 28, 31, and 32 providers. Oftentimes, organizations will begin speaking with us early on in the process when they're just contemplating a new facility expansion. And in addition to financing, we provide technical assistance, and that technical assistance is beneficial to groups as they are making critical decisions about facilities development. The next number I'd like to talk about is 7,750. As Ann mentioned, we're often working in underserved markets. We're working in markets where the economies are slow or are in a retracted position, where there's not a lot of revitalization, and we're looking to use our capital so that it also provides community impact. And one of the key measures for us is job creation. So with all of the projects that we're financing, we're also looking to see what type of job creation is part of the benefit to the communities that are being served. We're not looking only at job creation for professionals, but we're also looking at entry-level jobs and mid-level jobs. So you'll find that as you learn about our work, that you'll see us looking at social outcomes. On the next slide, I've provided an overview of our new program, our newest lending program, and it's the New York State Community Healthcare Revolver Loan Fund. And the great thing about this is it is a public-private partnership. We have entered into an agreement with DASNY, whereby we are named the administrator for a $19.5 million fund specifically to finance community-based operators. So that is the specific market that we're looking at. In addition to the money that's being provided by the state, we're also looking to leverage that capital with private sources of dollars from the banking community. And the idea is to marry both public dollars and private dollars. And we believe that this is a great way to deliver expanded access to credit for providers in the market. The purpose of the program, again, is to support the expansion that both Tim and Moira mentioned that's going on in the communities. And then last but not least, the features of our program, of our lending program, first and foremost, we're looking to provide affordable capital to organizations. And not only to those who have very strong balance sheets that are able to, receive funding from traditional or conventional sources of financing, but also to those who may need additional credit enhancement or may need gap financing where a bank is, not able to provide the full amount of funding that's needed, or in cases of facility development where it has to be done in truncated fashion, or they're relying on repayment from sources of grant funding that may come 1 or 2 years down the road, but they want to start the project now. So we are looking to be a partner with you. Most of our borrowers are repeat borrowers. They not only come to us once, but they come to us for their next facility and their third and their fourth facility. Loan to value can go up to 90%. Our maturities for this loan product can extend to 10 years. Amortization up to 15 years, so if you are a group that needs more relief for cash flow and you wouldn't be able to service this debt over a 7 to 10-year period, we can extend the amortization for up to 15 years. And then finally, the loan size in general is $500,000 up to $5 million. There is always flexibility, but that's really the target that we've set at this point. On the next slide, I wanted to mention two other loan programs that, as I've talked with people in the market, there are two other programs that I think are of interest. The first one is the Transformation Loan Fund. And, we've heard so much in the market about telehealth and electronic health records, care integration, and although some of that is funded by grants, and of course, grants first, loans second, some of those costs, you can't wait for the grants, or, there's an opportunity cost to, waiting 3 years for a grant for an electronic health records technology platform or investment when, maybe it should be done today rather than wait 2 or 3 years when you may have grant dollars. So at PCDC, there was a need to fill for this type of financing, and so we've launched a Transformation Loan Fund. And I know in discussions with Chris Tavella at OMH, he thinks that this is a great program specifically for Article 31 providers, that there's a lot of potential need for that. The loan size for this program is $200,000 up to $2 million. And then last but not least, Dr. Rugging mentioned those acronyms, and so New Markets Tax Credit Program is the NMTC program. This program is really suited for large projects that are $5 million and above in cost, and is a very convoluted tax structure. As you know, IRS rules and regs are always complicated, but at the end of the day, this program delivers a 25% subsidy to a provider for its project. So, if it's a $10 million project, whereas under a conventional financing scheme, you would be borrowing $10 million using the New Market Tax Credit structure. 25 or 2.5 million of that could be used as subsidy. So it's money that doesn't have to be repaid, thereby reducing the cost of the total project. The shortcoming with that program, one is its large size, but also it is a strictly place-based program in as much as you have an address, you code it into a geocoder, and if it doesn't pop up as eligible, it's not eligible. Sometimes we've seen projects that are eligible on one side of the street, not on the other side. Knowing about this program, though, is important because we do have some providers who are thinking in advance of their facility needs, and they may have 5 or 10 projects or sites that they're looking at and evaluating as acquisition sites. And this program may make a huge difference in which site they choose. So just something to keep in mind, and we have seen a couple of groups that I've met with, in Syracuse, Buffalo, have an interest in the New Market Tax Credit Program. So I'm going to stop there, and we can go to the next question.
Okay.
Okay, great.
Can I just add?
Yes.
I need a mic.
Mm-hmm.
Again, just a couple of words, what it's like, perspective as a board member. Very interesting dynamic. This is a board that's half composed of providers and underserved communities, and the other half by financiers. No accident, the PCD office is just off Wall Street. And so you have this dynamic of one side, the need being presented and understood by these providers, and the technical expertise coming at the governance level and also on the staff level in terms of how to navigate the trickiness and the convolutions of financing. And so, again, the formulas you've already heard from Lori is have PCDC secure as many public dollars as possible and then link them to private financing, JP Morgan or whoever, and offer the banks the guarantees that first of all, if that ever to happen, we're on PCDC, not of the banks, therefore leading to lower interest rates than would be possibly conceivable if you didn't have that interaction. Added to that on occasion is HRSA, government guarantees of the loans that further enhance the value to the financiers, making it more affordable to us as providers. So this is unique. I don't know of any other, certainly not in New York State, there's no other kind of entity that can work that arena. You might wonder, and I did when I first heard about this venture, well, what about from the Article 28? This is primary care stuff. Is this going to be a competition to us? I mean, now, are you guys going to be coming in here and looking for loans that we really need? And it's actually, of course, the reverse. And that is the more success PCD has in financing an expanded primary care arena, the more success they're going to have in government in terms of getting the public financing, making more available to all of us. You can imagine that the $19.5 million coming out of the revolver fund is only what is hoped to be the start. And if that can increase, we're going to have the kind of expansion in primary care the system absolutely needs. And then finally, just as an idiosyncratic comment, sometimes it's better to be lucky than good. We bought 5 years ago 4 acres of the last bit of open space in Glens Falls, thinking eventually we have to have a health center. And our finance team, some of whom's here, finally got around to looking at the map. Across the street is not new market tax eligible, but on our side, it's there. So that can be a huge, I mean, the benefit comes late, but 10 years later, 25% of the price knocked off is a helpful consideration. So that's, as I made to see as a provider, as a board member, how this looks and how it operates and why it works and why expanding it across New York in terms of scope of service matches everything we're trying to do at the policy side and then the program side.
Very good.
Thank you, Dr. Ruggie. Dovetailing on your comments, actually, nothing speaks louder than some examples. And so as a follow-up question to our panelists, can you describe your agency's role in working with a specific provider or providers that had success in completing a real estate project that proved to be transformative? And could you describe any kind of financial assistance the agency or PCDC has provided in helping that provider achieve that expansion or transformation? Increased access comes with physical expansion and transformation these days as well. Tim, do you want to start that off?
Sure. I can think of a couple examples, but I think one in particular comes to mind in terms of transformation. A local provider had a building on North Pearl Street, which I would describe kind of as a rundown fire trap. And it was getting cited for any number of facilities problems year after year after year. And at a certain point, they applied for a capital project and were approved for it. And they engaged an architect and developed a project which had to be done in some stages. It was a co-ed facility, so they had the luxury of moving the women to their women's residential program in another part of town while they renovated the floor that the women lived on. When that was completed, they moved the men down to that floor, renovated the floor that the men lived on, and then they worked on the counseling floor and so on. They continued operations during the renovations and so on. This took, Kevin, how long did the whole thing take?
No.
20 years.
No,
The only thing I think is important for everybody to know was we were told it was the worst building in the whole Oasis system at the time. Yeah, it took us about,
it probably was.
it took us almost 2 years to do it.
But it is a beautiful building now. What was the total capital expenditure?
About $4 million.
Yeah, but you got a beautiful building now. And on top of that, and there was an RFP, I think it was an RFP for the RRSY, and subsequent to that building, Hope House applied and was given an award for an RSY. They acquired some land. They built an beautiful RSY building there. And long story short, their agency's been transformed through the capital process. They have now 2 RSY buildings on that campus. They built this is kind of an aside to that. Their foundation was able to build a community building, a gymnasium kind of / community building. Oasis capital dollars have added, I think, an air conditioning unit, and is also renovating some administrative space in the building of the RSY. So their agency has been transformed through our capital process. And the reason Oasis is here today at this presentation is that we firmly believe that PCDC can assist our capital process in moving quicker.
Absolutely.
So with the Office of Mental Health, our capital projects have, as I said earlier, really been focused on residential versus clinic. But in talking about transformation, one of the things that stands out when we talk about case examples is neighborhood transformation and neighborhood revitalization. We've seen neighborhoods that really were really impoverished, but also the buildings falling down around them, and agencies have gone into that community, have brought the people who live within that community to help work on these projects and be part of this community revitalization. And we've seen some great successes with that. And we've been able to put our OMH capital with that, home and community renewal. We have low-income tax credits involved. We bring in what are the neighborhood needs are, what are those individuals' needs are, and I can see this project moving and doing the same with the capital revitalization for clinics in those areas, whether that be a dental clinic, a mental health clinic, whatever the clinic need is, but really bringing together communities. We just had a ribbon cutting about a few weeks ago up in Schenectady, over in Schenectady, on Albany Street, in a neighborhood that was really left to be. And the building's beautiful. The people who are living there are from the community. They absolutely love it. And they're excited because they feel like their neighborhood's going to be transformed. And they went from being ignored to having some pride in the building. So I think that's being seen throughout the entire state as well. So I see this mirroring that in so many ways. These partnerships. I think we use what we know and move it forward to what we can do.
Absolutely, yeah. And so I'll take a shot at it as well. So one of the case studies that I like to talk about is, and it's related to expansion. We, at PCDC, there was an FQHC, Article 28, that was looking, FQHC that was looking for funding for a project, and they had huge aspirations, and they were serving a community that had a lot of unmet need. And they went from organization to look for financing for this project because they had a clinic that was 2,600 square feet. It was at capacity. And they had identified a new space that was 20,000 square feet. And so we all know that, we're running out of space, and, there are a lot of unmet needs in our communities. But a lot of lenders just said, we can't figure this one out. It's just too large of a jump. And they have been turned down over and over and over again. And then they happened upon us. And as I said, we like to work with our borrowers not only on just providing financing, but really look at innovative financing structures. And we came back to them. We didn't say no when we first sat down. We said, let us go back and think about it. And we talked to our team overall, and we came up with what we thought was a good proposal for the group. And we suggested that they look to acquire this 20,000 square foot property, and that they relocate their existing clinic, which is 2,600 square feet, and that they leave most of the building unrehab or not rehab. So they rehab in phases based on patient volume and their ability to demonstrate, that the need that they're seeing in the market actually translated into demand and increased revenues. And so we were able to provide pre-development financing, we were able to provide acquisition financing, and then a small portion of the construction costs needed just for a portion of the building. A year later, 18 months later, they truly have met their projections, because we always require our borrowers to provide projections when they're doing new facilities. Well, they were exceeding their projections. They were doing a great job with their projections. So it was at that point that we were able to contemplate rehabbing the larger facility. And so if you think about this group, we started with them when acquisition, pre-development. We worked through the first phase of construction, and then we provided funding for follow-on construction. When the project was complete, then we were able to wrap that entire project into a new market tax credit transaction that really provided the additional subsidy to them as well. So I think that's one of the programs or one of the case studies that we like to talk about. We've seen projects here in this, in the state that also where someone is looking at purchasing a large facility, not quite sure if the demand is going to be there. They know the need is there, but need and demand are something different. And we've entered into conversations about how we might use this same structure as an approach. I'd like to talk about one more. It's an aspirational case study because it's something we're looking at. But I think Tim mentioned, this innovative structure that PCDC and OASIS are really contemplating and designing as we speak. And the idea is that OASIS, I believe the number is $300 million of capital projects are underway or planned, and that there's often a substantial amount of time. 430, I'm corrected. But that it often takes quite a while for those programs to move from paper to completion. And so the idea is that PCDC would stand in as an interim source of financing to start the project once OASIS has issued basically its letter of approval, which we look to as a permanent source of takeout for our dollars. So we're hoping that this new program or this new financing technique will allow us to be responsive, and it's critically important because of the opioid crisis and because of OASIS' desire and push to open up new detox beds and open access centers in the market in an expedited fashion. So I don't know if you want to follow on with that, Tim, but that's an aspirational case study that's in progress. We spent a lot of time, designing, and we think we have something that will work very well.
Can I go again?
Absolutely, absolutely.
It occurred to me of hearing all this that we're hearing from is the capital team for PCDC, but there are other parts of PCDC too, just to mention. And that is, some time ago, the organization embarked on expanded technical assistance. The technical assistance initially was for helping primary care centers, mostly FQHCs, reach PCMH, patient-centered medical home status. More recently has been morphed into value-based payment. And how do we get there? And I can well imagine the next morphing can be, how do we integrate behavioral health, substance abuse services, and primary care? And having this kind of expertise available is a really important. And then thirdly, you might wonder, well, there is interest to this, and it does generate money. What happens to the money? Where does it go? This is a not-for-profit corporation. Who uses that money? And the answer is, it's used by PCDC for advocacy. So even though there's state government here, you might be surprised here, PCDC does advocate, we certainly don't lobby, but for expanded funding, for expanded consideration of regulatory flexibility, all those things we need. And really, really important, I think, in the corridors of power to know this is coming from the finance industry as much as it is from the provider sector. And so there's a synergy here that we see with PCDC that is akin to what we do in our lives as providers of care. So one more reason for sticking with an organization like this that was thought to be a short-term grant-generated thing and turned into an enterprise that helps us all. I conclude.
Thank you, Dr. Argan. And on that note, it's worth giving a quick shout out to one of our colleagues, Patrick Kwan, in the back of the room. Patrick is, so you're seeing some of the folks on the financing side. Patrick heads up our policy and advocacy group. And it's not surprising we see him up here. Half of his time, I think, is spent in Albany, and the other half is helping us understand the policy framework, both at the state and the federal level. You know, it's as we've continued to work through integrated care and get to know the Articles 28, 31, and 32, there is a saying, if you meet one medical or behavioral health provider, you've met one medical and behavioral health provider. And one of the things that I hope you kind of take away, at least from Lori's remarks, is, and I think it's certainly true, speaking for my colleagues on the financing side, that PCDC is nothing if not innovative. And so when we speak with providers and they share their aspirations, but their challenges, we try to work through those and try to meet them and get them to where they want to be eventually. It may not happen overnight, but certainly in the case study that Lori mentioned, over a span of 2 years or more or less, that provider went from literally a storefront. It could have been 50 years prior, a candy store. It was right on the street, to now the sole provider of dental services to low-income people in a fairly large city. We want to be respectful of everyone's time, and we have a couple of other questions, but we'd like to open it up to the floor for anyone who has any questions of certainly the agencies. You have the leaders of OMH and OASIS right here, and certainly PCDC would be happy to. Yes, sir.
Hi, I'm Barry Brogan, the Executive Director of the North Country Behavioral Healthcare Network. We're up in North Country in Saranac Lake. We're very involved with a group of 14 providers that are putting together one of these BHCC applications to build infrastructure among Article 31 and Article 32s to get ready for value-based payment, ultimately to get into some contracting. I believe the focus of our project is going to be a lot to do with data. So I was very interested in the loan program that would support data and technology platform infrastructure. And my question is, this is kind of new stuff for us. We're going to be working with our PPSs who are already doing data warehousing and data analytics, but they're only going to go so far. And we think, if we think of this as like kind of the electrical grid or the cable system grid, we think they're going to, put the wires up and the poles, but we're not sure they're going to do that last mile or that, connection between the grid and our agency with regards to data analytics. What do our agencies need internally to make the decisions and to gain the efficiencies and quality to be competitive partners in a BBP arrangement? So my question is, so we have a group of 14, we think we're going to be pretty well organized, we're probably going to be starting an LLC to move together as a group, but when it comes to kind of developing the financing that could really pay for robust data analytics, we're going to need both probably the TA piece as well as perhaps the loan piece, although at this point in the game, I don't think there's a clear vision about how ultimately that loan could be paid back. So could you talk about a little bit about groups that are facing this this challenge and how to move forward? Thank you.
Well, you had me up until the part where you didn't know how it was going to get paid back. No, I'm kidding. I'm kidding. So we're working. That's right. So I think you're spot on. This is a thing we're hearing percolating both at the network among providers of various types, as well as some of the trade associations, the PCAs, the primary care associations that we're working with around the country, frankly. So obviously the details, Lori and any of us would be happy to chat about later on about the specifics of the project. But in terms of the transformation fund that Lori had talked about, the capital is designed, and both the transformation fund and the fund that we're working on with DASNY, the capital is designed to be what we call patient. So it would, meaning we would not expect it to be repaid right away. It wouldn't be functioning as what you might call a more traditional construction loan or a permanent financing that would begin amortizing immediately. Obviously, there are going to be some structural nuances to it. How, for an organization that may not yet exist, how would that organization finance a loan? Obviously, it's going to be dependent upon the members of that network, and that's where the conversation would go. But we would think about structuring the loan most likely to see, well, what do you envision the trajectory of this network being, this IPA being, and when would it begin to throw off revenues, and that type of thing. I don't know if you have any.
Yeah, no, I would agree, and I would say that Bill and I are going to be making a trip up your way soon, so let's make sure we sit down and chat when we're there. We heard a similar ask yesterday when we were in Syracuse, so I think that it's something, we'll probably hear over and over again, and we'd like to sit down and take a look. And I think Dr. Ruggie said that we're out there looking for sources of subsidy all the time, sources of grant subsidy to help, finance things that, require patient capital. So I welcome the opportunity to chat about it, and thanks for bringing it up.
Thank you.
Sure.
Sir, I think you had a question. Yes, sir.
I'm Bill Panatinto, and Director of Special Projects at St. Joe's Rehab Center, also up in the Adirondacks.
Yep.
I know we've been having some conversations.
Yeah.
I also do some consulting work for a number of other voluntary agencies, especially rural agencies in upstate. What I was struck by was when you talked about the building with 20,000 square feet and how they did it sequentially and ultimately were able to build out. And I'm assuming that was a New York City-based project. No, it wasn't,
No.
but a relatively larger city. In the rural communities, everything is scale. And what I'm wondering is, are you all thinking about not only integrating in one building primary health care, mental health, substance abuse services, but also perhaps attracting other community-based support systems, like a community center, like maybe even some on-site community college programming. In other words, creating a community center where people will be attracted to different pieces of the service, sort of a multi-purpose center. Is that something that is possible within the PCDC?
Yeah, absolutely.
Yeah, absolutely.
Yeah. So this is really a great question, and it's something that we've been working on both at PCDC as well as in the community development space, is this recognition that historically many of us have come in and financed single projects, right? There's a building that needs to be developed and is delivering X services. And I think we all recognize in many of our industries that are very focused on serving a community that we need to step back and think about what are the comprehensive needs of that community. We've been working with a number of our peers, other CDFIs, banks, to figure out how do we come in and work with the community and understand what are the needs of that community. And then how do we bring different partners in? You know, our specialty at PCDC is really primary care, but we have a lot of colleagues that are really knowledgeable and have expertise in history, in affordable housing development, or social service, or bringing in retail. That community may need a supermarket or may need other services that don't typically fit within what we may think of as community development. So it is something that we are exploring, and we've been working with a number of colleagues to come together and work in, with a very place-based focus around what does that community need. So sort of my long-winded way of saying we may not be able to do it, but we do have the ability to bring our partners in to do that.
I'd also add that a number of projects that we've financed have sometimes have excess space designed into them, and but that's more ancillary to obviously their main focus. And but if it was certainly larger, then we have partners that we work with all the time that could help with that. Mm-hmm. Yes, ma'am, in the back. Yep.
Andrea Smith, the Coalition for Children's Behavioral Health. So you've identified so many of the challenges that the residential children's behavioral health provider system are facing. The issue of how long is the state's commitment to a service? Is it shorter than the length of the bond to build the facility? And we are facing that with residential treatment facilities. At the same time, the same providers are trying to take advantage of the opportunity to integrate care and shift to outpatient. So, we have this old debt that you can't use to transform the building because the building needs to be filled to pay the bond. And the new commitment to follow, to meet the nexus of the next phase of services, expanded outpatient or integrated primary care, kind of on the same campus or by the same provider. So I have two observations regarding that. You've identified the problem, but here we have to figure out, a solution.
Right.
One is to give a name to your aspirational, hopeful design project and call it the Bridger Capital Initiative, because we certainly have successfully lobbied the state legislature to get some capital funding for the residential treatment facilities, but the ability for OMH to work maybe more quickly on the pace with a partner would be very welcome from our perspective. And then secondly, just to ask, do you do some projections or visioning about the state's commitment on a model of care, because, you know, we're addressing the capital needs of the opioid crisis, but what happens 10 years from now when you have a 15-year loan on a building that's no longer needed? Because that's the crisis that we're facing in the children's residential treatment process. As we move to managed care, the facilities are being deemed unnecessary, but the debt stands.
I suppose I should answer that one, right, Jim?
Please.
You mentioned the Children's Capital. First of all, I work in adult services, so I'm not that well versed in the children's programs, but I will tell you what I do know, and I'll tell you what we are talking about. We've had a number of discussions about the $10 million in capital that's specifically earmarked to rectify some of the challenges in the RTFs and renovations, but also what other technical needs are there to support the children's system. So that is one conversation that's happening now. There'll be an RFP on the street very soon to respond to the capital needs within the RTFs. However, I think also if there's bond debt on it and it's DASNY tied, we would work with DASNY to see how that bond would either transfer or we'd sell the building. I mean, there's a lot of options, but there's also a lot of discussion to be had. It wouldn't, and again, I've got my adult head on, so I know it's a little different. But I will bring back that specific question to Donna Bradbury, certainly. But I do know the $10 million for capital RTF renovations, upgrades, is very close to being on the street. And certainly we would welcome partnerships. We also recognize that things need to move quicker than sometimes they do. The problem being with any kind of construction, restoration, or revitalization is approvals. It's, you know, architects, it's getting everything in line. So you're looking at an 18-month project if you're starting from ground up at the earliest. In these cases, certainly it wouldn't be because the buildings are existing and the renovations would be much quicker. So I know that's probably not the full answer you wanted by any means, but I can certainly bring it back to Donna.
Yeah, this is kind of a follow-up to Bill's question comment. And I was very glad he brought it up because especially in rural, smaller communities,
Right.
it's very, very difficult to fund X program, Y program, blah, 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 blah. One of the things that we've talked about where I'm from in Columbia and Green is trying to combine different services in the same building for all kinds of economy. And my understanding, unless this has changed, is that there are regulatory prohibitions about having certain services in a building co-located with other services. And I'm wondering, is that a possibility to get a waiver for or change or whatever, depending on the needs of the community? Because they're just very, very different when you come from a larger area to a smaller area. And it really prohibits people from being able to benefit from the economy of scale.
Do you want to check about that?
I'm not sure what services you're talking about now.
I'm not talking about anything specific other than I know that we could co-locate with mental health services in the same building, but there are other kinds of services that we've been told we can't co-locate with.
Speaking as a real amateur, you can be in the same building, but can't use the same space within that building. So you can't use the same waiting area for two groups of patients for two services unless a waiver is secured, and that's always iffy.
And that's a federal
The information
regulation.
I've been just given, coming to this thing, is that we can now finance integrated projects to co-locate OASIS, DOH, and OMH.
Yes, I understand that. I'm talking about services other than that in the community. Social,
Yeah.
more social services. support
Non-mental
services.
hygiene projects is
Non-mental
another
hygiene.
story.
Right. That's exactly
But
my
that's
point.
really what you need in rural communities. You
Exactly.
also need where people will be attracted to come to. So for some people, it could
I'm
be
sorry.
literally retail, it could be child welfare, childcare, a daycare center, it could be on-site course work
Right.
for GED or even a community college. There's just, it's a community center. It's almost like the old settlement house kind of concept. And why can't that be an appropriate rural, especially rural model, probably even in communities in urban areas as well?
I mean, I know
Well, certainly-
originally one of the things we were told years ago when we talked about this was they didn't want to co-locate all those different kinds of services because of stigma. Well, it seems to me it's more stigmatizing to have a place that says, this is the place for drug addicts, and this is the place for mental health people, and this is the place for childcare, rather than having it all in one building, where you walk into a central door and nobody knows where you're going.
Well, certainly, I know there's a number of work groups going on within the behavioral health and health system in regard to integration, and we'll put the rural issue on this agenda topic to talk about that and bring that back.
Outside the mental health.
Outside the mental health.
Right.
I appreciate your input into that.
Thanks.
Yes.
I know the state is not thrilled with the concept of a design build. So my question is twofold. Will the state, and I don't know whether it falls under the agencies or DASNY or, I don't know, but, will the state look at expanding and allowing agencies to do design builds? And does your organization allow people to do a design build? In general, I mean, I think so we've done, OPEF's done 3 capital projects, $15 million. And I think we could have done it much quicker and much more inexpensively if we were allowed to do a design build. So again, in that concept, we hire a construction company, they would design the project, and then the construction company would build the building.
We've done some.
Can we go more down that road? Or, I mean, what do we need to do? Will the state allow us to do it, and is there a mechanism to do that instead of doing it the traditional way we've done it?
I probably shouldn't talk for the capital unit, but I suggest you talk to them.
Okay, fair enough. And
We've done it, and we are in the process of doing it.
Yep,
Other places.
I think so,
and
yep.
even locally.
And does PCDC, do you allow a design build? Great, thank you.
Hi, Peter Grosofsky, CEO of Damien Family Care Centers. One of the things I think to mention with New Markets tax credit is the ability to leverage a grant that an organization might receive for capital purposes. So it makes it very attractive because that 25%, and then if it's just an example, $10 million capital grant, you can grow that to $12.5 million capital grant per se. But one of the challenges in doing that in the past was the language that must be in the contract for the capital grant, and getting that language changed, and I don't want to single out a particular agency, but the agency's ability to get that language changed. So I would just ask that the agencies maybe look back at that, because if that could be looked at in advance, it would help out with the New Markets tax credit process. Because the one that I was involved with a different organization, it took like 6 months to get that language changed. And it was with PCDC, so they were very instrumental in getting that particular, it was a $30 million New Markets tax credit deal. But it was very difficult to get that language changed, and we were able to get it changed, but it was a lot of work. So I would, whether it's DASNY, OASIS, DOH, OMH, to look at that, what in advance, what could be done in the contract for capital grant that could help out an organization to leverage that for federal tax credits under the New Markets tax credit.
That's actually a really great point, Peter. There we go. This is always dangerous. Yeah, so just a little background for everyone. There are sometimes restrictions with the capital grant programs around whether or not they can be married and paired with new market tax credits. But there are sort of interesting ways to structure a financing with new markets around how different funds flow through, whether they come directly to you as the sponsor of the program or whether they're going through the investment fund. And I don't want to get into that whole explanation because we'll have to start bringing out flow charts and it just gets very complicated. But it's a really great point. If you are marrying debt, grants, and bringing that together under a new market tax credit financing, you can actually build out the basis for how you're earning the subsidy. So it's a really fabulous point. It's something that has evolved with the program to allow for these larger pools of capital to include the grants, and then get that benefit of the basis being the full cost of the project, including all of that. But there are some nuances around how you are bringing, different sort of government sources of capital around a federal program. The last thing I would say, and only because I feel like there always needs to be a disclaimer on new market tax credits, and I don't know if we have any people from the IRS in the room, so I'm always really cautious here. It's not debt forgiveness. It is a subsidy, but it does require that you comply with the program for a 7-year compliance period. So similar to, I think, what we've seen with affordable housing, as long as you're operating the project, your programs in accordance with the new market tax credit IRS rules, and you stay in compliance with all of the reporting for a 7-year period. At the end of that 7-year period is when you really earn that subsidy. But it does, at the end of the day, allow you not to have to raise an additional 25% of debt or grants or whatever to make that project possible. Sorry, I just feel obliged.
That's great. Any other, yes, sir?
So, in the spirit of expansion, the governor has made available a fair amount of money to do permanent supportive housing. And I'm hearing you talk about supportive housing, so I'm wondering how could what you do or how you may interact in the capital arena support some of these projects that are being funded through the Empire Supportive Housing Initiative, where you have providers coming in with support and operations funding, just looking for capital dollars to move forward with the capital part of the project. And I heard someone talk about mixed use, so I'm wondering is maybe the opportunity to build a building that may have a mixed use of retail and supportive housing or something like that.
So certainly a lot on the housing side. So PCDC on its mission is primary care. In fact, in that sense, just to echo a little bit of what Lori said earlier, where CDFIs typically have a broad mandate to provide financing in activities that support communities and develop communities. Housing is a leading example of that. PCDC is a little unique in that we're a very singular CDFI, so we're focused on primary care, having acknowledged that the definition of primary care is evolving, and certainly behavioral health may have some kind of housing component. In terms of more long-term housing, there we typically partner with our other CDFI partners, whether it be on the financing, et cetera, and bring them in and their expertise. They really bring an awful lot to the table. Certainly we've worked on projects that have had housing components as well as primary care, say a co-located thing or a developed space that has a primary care component and a housing component. And we'll work together with those CDFIs to help finance that project. And we could certainly make those introductions if.
To say this, so if a provider was interested, what would they do? Just start by having a concept and contact you?
Yeah.
Okay.
Yeah, absolutely.
All right.
One question that that has come up. This is our third meeting. We had a meeting in Buffalo, Syracuse, and now Albany. And one aspect, and it's certainly reflective in this room, is the juxtaposition of the urban and rural delivery. And I certainly, we've alluded to a couple of comments about rural delivery. I think that both transformation and expansion come together in different modalities of delivery of care. And I think that is certainly applicable for more rural settings. And I haven't heard telehealth come up. I know certainly telepsychiatry is something that's kind of a hot topic these days. Another is maybe the delivery of healthcare through mobile means, like mobile vans, et cetera. I don't know if anybody has any comments on that. Certainly we have financed both, and we would be, I'm just putting it out there, we'd be happy to talk about that. Sometimes those things, you see something up on a slide and you say, okay, that's what they do. Mine is something different, and I just encourage folks to have that conversation because we're eager to explore innovative methods of delivery. Expansion isn't always bricks and mortar. I just wanted to make that point.
Can I
Absolutely.
add also? In regard to telehealth, I had the opportunity yesterday and the last couple of days to be at another conference taking a look at, again, residential programming. But we had a commissioners panel yesterday, and at that panel was the Department of Health, our commissioner at the Office of Mental Health, and 5 other panelists. But we were talking about the need for a long-term care assistance for individuals who have behavioral health needs who want to age in place. And what do we do about that, and how do we start addressing that? And the area of telehealth came up. You know, we focus so much on the behavioral health issues, but at some point in life, the behavioral health issues are no longer the real issue that someone's dealing with, but it's an aging issue, and it's a healthcare issue. So I think it's important to remember telehealth, even separate than telepsychiatry, when we talk about how do we keep and help people maintain their lives in their homes. So I think that was just an important thing that everybody in the system is really starting to talk about, and would this be an opportunity for those agencies to really come together, partner with the primary care physicians that are working with these individuals, and provide telehealth needs for long-term stability.
Thank you.
Anything else? So we're a couple of minutes early, but that's perfectly fine. The food's not going anywhere, so if you haven't already had something, oh, it is gone? All right, take it back then. Oh well.
Well, I think there's still coffee.
There is still coffee and juice, etc. So right at this point, if you haven't eaten, too late. So first, I would like to certainly thank you all for making the trip here from wherever you're based, and this was another great conversation. Certainly, I'd like to, PCDC appreciates the agencies, Moira and Tim, for coming, and Dr. Uggie, our board member, we appreciate, as always, your support of what PCDC does. This is officially now a networking session, so we certainly have the space, and we welcome your conversation amongst yourselves or just meeting us with any one-offs. So thank you very, very much.